our two guests that we have on this Zoom event tonight. We're very lucky to have two experienced board-certified physicians who specialize in the care and treatment of older adults. So first, let me introduce Dr. Tom Lawrence, who is a board-certified geriatrician. He is the medical director here at Barkley Friends, as well as at our sister community, Kendall Crosslands, and several other local senior living organizations. He also serves as the System Medical Director of Geriatrics and Long-Term Care for the Mainline Health System, and he maintains a private practice nearby here in Newtown Square. Dr. Robert Brus is a board-certified internal medicine physician who has specialized most of his career in geriatrics. He's licensed to practice in Florida, Delaware, and Pennsylvania, and he has served as Chief Quality Officer and President of the medical staff for the St. Francis Hospital. He serves as an attending physician here at Barkley Friends, sees many of our residents, and he's affiliated with Team Health. So I'd like to welcome both Dr. Lawrence and Dr. Brus, and hopefully we'll have a nice conversation this evening on the topic of what it means to have a healthy old age. So Dr. Lawrence, Dr. Brus, I'd like to begin by asking, why did each of you choose to work with the geriatric population? So I'll start with Dr. Lawrence. Why did you choose to work with the geriatric population?
Well, it's a good question. So over 30 years ago, when I was finishing up my internal medicine training, considering what to do with my career, I was actually in the medical library at where I was training, and I saw a newsletter from the University of Pennsylvania Aging Center. And that's how I first found out that there was actually fellowship training in geriatric medicine as a specialty. So I applied, I started my fellowship as a 2-year fellowship. Had little idea what I was getting into, since at that time, geriatric medicine was a fairly new field. And we find ourselves now, it is a shrinking field, actually. There are very few people going into geriatric medicine or seeking special training in it. But I was delighted to find out that I liked it, that it was challenging, that there's lots of opportunity, and there's tremendous need, especially as you point out, in long-term care settings, where there are relatively few clinicians who want to practice primarily, long-term care practice. Personally, I always tell people I was very close with both of my grandmothers who lived to very old ages. So that's the only explanation I could find, is how I was drawn to it personally.
And that's a good reason. Our population is rapidly aging, and we know that the largest cohort in history is moving into their older years. That would be the baby boom. So, you've probably heard the joke that 60 is the new 40, and now it's becoming 80 is the new 50. What's your definition of old age? It seems to be shifting.
Well, it definitely has shifted away from 65. When the Medicare program was started back in the early 1960s, 65 was sort of somewhat arbitrarily chosen as the age when retirement would start and Medicare coverage would begin. That was based on some actuarial data from England, actually. And what we now know is everything that we consider in care of seniors really applies to a significantly older population than that. It really is closer to starting at age 75. So it's actually quite true that if you say anything, 75 now is the new 65. Thinking about senior populations, things tend to break into a couple of different subdivisions and roughly linked with age. And I'll mention a few of these. One is the sort of 65 to 75-year-old population, which I refer to as the golden years. Now, we all grew up thinking everything over 65 is the golden years. Turns out for the average American, you can probably count on 65 to 75 being the golden years. That is when you have pretty good health and functional health. You can do what you want to do. You can do much of what you used to do. But as Americans head toward age 80 and certainly 85, things change. Accumulation of problems related to chronic conditions, impairments from chronic conditions, onset of cognitive impairment in some people, and those sorts of things. So there's another group that we refer to as multimorbidities, that is people who have numerous chronic conditions, who might have high blood pressure and diabetes and COPD and heart disease or heart failure. And that sort of paints a picture of what daily life might look like. And then there are people who develop frailty, not necessarily based on these types of chronic diseases, but lose functional reserve because of advanced age and perhaps severe arthritis. So their ability to walk is impaired and so forth. And so it sort of breaks down along those lines. Then the extreme seniors, typically defined as age over 85, who tend to have various combinations of these things, and who sometimes, because of age-related impairments of various types, can become frail quickly, or can have onset of multiple simultaneous conditions quickly. So it's not purely age-related anymore, which is more or less what your question implied.
So Dr. Brus, we'll circle back to you. How did you start to work with the geriatric population?
So, and thank you for the opportunity to be here, Linda, and welcome to all of you. My choice in choosing this medical path really was born out of my training in internal medicine. The vast majority of the time you're spending in the hospital and with the geriatric population. And as Dr. Lawrence had alluded to earlier, there clearly is a need with the baby boomers aging. They are the largest segment of the population, and there clearly was a need for that in the medical field. When I first started my practice, I was also very interested in being affiliated and part of nursing home populations. I was the medical director of 3 facilities in Delaware when I first started it, and I knew right away that was the path that I wanted to be on.
Do you want to comment at all on Dr. Lawrence's thoughts about what the definition is nowadays of old age?
I think that's a moving target as our population is aging and the life expectancy is increasing. I think that's a truly a difficult definition to put a definition to.
So let me ask both of you, but I'll start with Dr. Lawrence. Are we saying here that aging and disease are pretty much synonymous? In other words, can we just expect that some of these things that you named, Dr. Lawrence, they're going to happen as we get older?
So the answer to that is not necessarily. And one of the assumptions in general culture is as we get older, we get more like each other. Turns out nothing could be further from the truth. The senior population in America and most countries is actually much more diverse and heterogeneous than younger populations. So there are some people that we refer to as successfully aged who will not develop common chronic diseases such as high blood pressure, elevated cholesterol, heart disease, lung disease, and so forth. But will be relatively spared. So for that reason, we know that age and having chronic diseases are not directly linked in all people, but there are subsets of people. And so I think some of your other questions may get to the question of, well, how do we live our life to be found in that successfully aging population rather than a situation where we have multiple chronic diseases? And that's a challenge, which is addressed partly by genetics, partly by lifestyle habits, in our youth and middle age and so forth. But aging and disease are not synonymous. As I think we're going to talk about, there are a number of conditions that are so common you wonder if they're normal, but not exactly. So I'll stop there and see what Rob thinks.
Yeah, Dr. Brus, I'll ask you this because it kind of takes off where Dr. Lawrence left off. What are the most common conditions that you see in older people, and which of them in your mind can be prevented? You see people when they're not so well, but do you see a way that some of those conditions could have been forestalled or pushed off?
Right, exactly. As Dr. Lawrence had mentioned, obviously the most common problems that I run into in the population are the common ones that he discussed: hypertension, diabetes, cerebral vascular disease. These are the most common things that we are focused on in this population. Can they be prevented? I think that's a good question. I'm not certain they can be prevented as much as controlled. I think a lot of your lifestyle modifications, compliance with medications, following up with doctor visits, and healthy lifestyle will help control those situations. As far as preventing them, I'm not certain that's the case. I think, as Dr. Lawrence alluded to, genetics does play a big role, and unfortunately, you don't get to choose who your parents are.
Right. So Dr. Lawrence talked about that the older population is not, what was the term you used? They're heterogeneous. In other words, they're very different one from another. So one 80-year-old, you look at an 80-year-old, not necessarily like another 80-year-old. What do you think accounts for some of the differences in biological aging?
I'll actually want to tag on to some of Rob's comments about conditions. So I actually looked up the CMS data on the most common conditions, because that question of preventability is, of course, very interesting. So there are two conditions that are so common that you would call the norm, but not normal. High blood pressure, which more than 50% of seniors in America have, it's like 58%. The other is elevated cholesterol, which is just under 50%. Then there's a group that's about a third of seniors have these conditions: coronary heart disease and arthritis. Diabetes is shortly behind that, with almost more like a quarter of Americans. And then other conditions: chronic kidney disease, congestive heart failure, Alzheimer's disease. Overall, you say which of those might be preventable? It's actually relatively few. Arthritis, of course, some forms of arthritis are from overuse. Remember a few years ago, before the Super Bowl, they had all the Super Bowl MVPs, most of whom were running backs, come onto the field. Every one of them was limping, and they were like 52 years old. 52 to, they were young. Some of them were like in their 40s. So obviously, my wife, who is a runner and whose knees are starting to bother her, is probably going to have arthritis of the knees that might have been preventable by avoiding, that shock. But most of these conditions really aren't preventable. Of course, COPD prevented with not smoking cigarettes, but most of the other conditions really not very preventable. So in terms of what can you do differently to prevent some of these things? And the things we always come to are, diet and lifestyle. Diet, really, most important thing is avoiding obesity. Of course, we all know there's an epidemic of obesity among like teenagers, right? So shocking that wasn't present in most of people over the age of 65 now. Most of their childhood, obesity was not a common thing. We all had a few people in our elementary class who were obese, but it was more uncommon. Now it's very common. And that's purely a diet lifestyle issue. So things like that can make a difference. The lifestyle in terms of exercise, many chronic conditions can perhaps be delayed, if not prevented, by exercise. Diet, probably the most important thing for delaying that most common syndrome, hypertension. There are populations in the world, very few, where there is no sodium. classically, the tribes in New Guinea, in the mountains of New Guinea, have no access to sodium. They have no hypertension as they get older. Whereas in the United States, salt is everywhere and in everything. And if we try to avoid it, it's very difficult, not only because food tastes so bad compared to what we're used to, but because it's in everything around us, you can't avoid it. So I think if you're going to talk about, what can you do to be the best 80-year-old you can be, it would be, in youth and, younger adulthood, diet, exercise, avoiding, habits like cigarette smoking, weight management, and so forth. So I'll stop there.
Okay, Dr. Brus, what do you think about that?
I completely agree, with everything that Dr. Lawrence said. As I said before, earlier, not so much preventable as it is controllable with these other factors.
So let me toss this one to you, Dr. Brus. If someone has a genetic predisposition to disease, say there's cancer in your family or heart disease in your family, the expression, the horse is out of the barn, there's nothing I can do about that. Your future health is out of your control. Do you think that's true if you know that there's a genetic predisposition in your family?
Out of your control, absolutely not, but something that needs to be monitored. You should be aware of, if you have access to that family history, to know, which will help guide you and your medical team with decisions regarding your health and testing and medical therapy going forward. For example, colon cancer comes to mind. As I'm getting to that 50-year-old mark, I know that it's time for my screening colonoscopy. And it's important to know the family history of, does colon cancer run in the family? That doesn't necessarily earmark you for that condition, but it is certainly important in, again, making those decisions regarding getting the screening test done, making sure you follow up, seeing physicians if anything should come up on a sooner basis in regards to that. But no, it does not completely make you with that condition.
So Dr. Brus, talk to us about the role of diet in healthy old age. Let's pivot from disease to healthy old age. What do you see are the things that an individual could do with their diet to perhaps lead them to a healthier old age?
Well, I think diet is extremely important when it comes to overall health, old age, young age. As Dr. Lawrence alluded to earlier, obesity is a significant problem within the American population. The old adage, you are what you eat, and it really is true. So in regards to the earlier question regarding preventing disease, as I alluded to with the controlling of the disease, hypertension, diabetes, dyslipidemia, cerebral vascular disease, a lot of that can be controlled with just diet alone, lifestyle modifications. So I find it extraordinarily important in maintaining good health, but also in the treatment of underlying disease processes. When I was a hospital specialist, I actually was part of the medical nutrition team because of the importance in the treatment of a hospitalized patient and their condition for which they were admitted to the hospital for. It was an integral part. It's not just medications and consultations and testing, but I found it extraordinarily important, not only in the control and prevention of disease, but also the treatment of the disease process itself.
Do you have much success getting your patients to comply with your diet recommendations?
Yes and no. I think a lot of it depends on the patient's motivation to get better or to be better. Unfortunately, as Dr. Lawrence mentioned, a lot of us have been pre-programmed, and I think it's going to be even more difficult for the younger population as they age, with the access to fast foods, the sodium, the fats in our diet, the sugars in our diet. It's ubiquitous now compared to other populations around the world. Just like with smoking, it's very difficult to get somebody to change that has already had that habit. So to answer your question, have I been successful? No, but you have the conversation with the patient to hopefully help and guide them along that path.
Great. And Dr. Lawrence, how about exercise? I'll preface this by telling you that I'm a former runner myself, and last week I got my first cortisone shot in my knee. So I guess I'm heading down that path myself. But what about exercise as people get older and perhaps they start to have arthritis, they start to have other issues? Is exercise still recommended for older people?
So exercise is highly recommended, but probably different. As we age, what we do for exercise sort of shifts. For example, instead of running, walking becomes much more important. Stretching, for example, becomes very important. And in fact, stretching is probably the most important thing to do to maintain flexibility. And I'm unfortunately finding this out in my very early 60s. If I go a day without stretching, a chronic back problem I have, it gives me pain all day. If I stretch for 10 minutes in the morning, it's a whole different day. So it's a difference in what we do with exercise. But both endurance training with walking and strength training with very light weights, for example, can help with balance, flexibility, range of motion, just daily functioning. So it's a different type of exercise than most people think about compared with younger people. It's not so much getting your heart rate up to a target for 15 to 20 minutes, 3 days a week necessarily, as it is other types of exercise. And coupled with things that also promote social engagement and may enhance cognitive functions. So group activities that involve exercise. For example, the fastest growing sport in America, I'm told, is pickleball. So, anytime you see pickleball being played, a lot of people have gray hair who are playing pickleball. It maximizes balance and, of course, the social element of group exercise. So that type of exercise is sort of a different way to think about things. Also the way the dieting, may be different. To get back to the point Dr. Brus was making, the other caveat with all these things is anything we recommend has to be balanced with the person's personal goals and quality of life considerations. For example, anytime I see, usually anybody over the age of 85, very rarely do I recommend any major dietary change with the exception of watching out for sodium, because sodium is critical in high blood pressure management and congestive heart failure management. So when we see two conditions like that, it's all about sodium. Diabetes, we've gotten to the point where we have so many medications available to treat diabetes short of insulin that there's lots of options without really restricting somebody's diet who has type 2 diabetes. Another example is cholesterol. So there's lots of new research around cholesterol that for primary prevention, we probably shouldn't even be treating it in people over the age of 80 who have not had heart disease, stroke, peripheral vascular disease, and so forth. But compared to what diet intensity to lower cholesterol versus a low dose of a statin drug, in terms of quality of life, the low dose statin is such a better way to go to control cholesterol than the severe restriction that dietary interventions would have to do to achieve the same lipid numbers, for example. So I'll stop there.
Yeah, Dr. Brus, do you want to comment on that about the use of pharmaceuticals like statins and blood pressure meds, and really to a certain extent advances in cancer treatments? Do you see those helping people live longer and healthier lives and more active lives than they used to?
Absolutely. As Dr. Lawrence had mentioned, clearly there is that balance that has to be found, when it comes to, especially dietary restrictions. You want to optimize everybody's quality of life while trying to keep them healthy. And as I've told many of my patients, I'd rather see you eat and eat a little bit unhealthy than not eat at all. Malnutrition, as people age, becomes a more important factor, especially in patients with dementia and cognitive impairment. So finding that balance is absolutely critical. And my philosophy is, always focus on non-pharmacologic therapy whenever possible. If you can change somebody's lifestyle while maintaining their quality of life, if that mitigates the need for medical therapy, I am always in favor, of doing so. I try to prescribe the least amount of medications as possible. But clearly, advances in medical science and testing and pharmaceuticals are increasing our life expectancy, are improving our quality of life, and should be utilized when appropriate.
Thank you. Well, let's pivot now to a different subject, and that's mental health. So as you both know, older adults suffer really high rates of depression and sometimes anxiety. So Dr. Lawrence, I'll start with you. What are some of the best practices for older adults to prevent or address anxiety, depression, other mental health issues that can occur either before old age or during old age?
Sorry, I was muted. So depression, of course, is extremely common as we get older, as is anxiety. They are often linked. And what we know for depression is, although antidepressants are pretty effective, any given antidepressant that might be prescribed is 60+% effective for treating, acute depression, which is pretty good efficacy. And sometimes we have to add or modify treatment to get higher percentages of response. It's often understated that psychotherapy, talk therapy, for lack of a better descriptor, is equally, if not more important in conjunction. For anxiety, for life adjustments that result in depression or anxiety, talk therapy is really the primary treatment. And this could be group therapy, it could be one-on-one therapy with any type of therapist, not necessarily a psychiatrist, could be a psychologist, could be a social worker trained in therapy, nurse practitioners trained in counseling. So to realize it's not just about medications is important. We're learning more about how improving sleep and exercise is an important part of treatment for anxiety and depression. Staying in touch with family and friends, important part of the treatment recipe, and of course, staying active. We know that in the wintertime, especially, the winter blues are actually a real thing, now referred to as seasonal affective disorder. We know if there's a simple thing we can all do to help curb that, take the edge off it at least, it's vitamin D supplementation. What we know, people of all ages become relatively vitamin D deficient in winter months as the sun doesn't regularly, hit our skin, where vitamin D, the chemical reaction where vitamin D is produced in our skin. But for seniors, it's particularly important. So vitamin D supplementation is an important part of that also.
Dr. Brus, do you want to comment on that?
Sure. No, I completely agree. You know, there's the medical aspect of patients' healthcare, and there's the psychological aspect of patients' healthcare. You know, for the seasonal affective disorder, especially up here in the northern climate, you can do like I did. You move to Florida for 6 years, and then you'll never have a vitamin D deficiency. But in all seriousness, you know, not everything. I always tell my patients you can't necessarily find happiness in a pill. This pandemic has been an utter disaster, especially for our elderly population that live in facilities with all the restrictions that have been put in place regarding visitation, the lack of interaction with your family and friends and loved ones, in addition to the lack of interaction with other residents, is you know, again, that is part of the benefit of being at a facility like Barclay Friends, where there's structured activity. There are other residents in the same kind of situation. That social interaction piece, I don't think can be understated. It's extraordinarily important for the well-being of everybody. And as Dr. Lawrence alluded to, having that psychotherapy piece, again, not the psychiatric piece, not necessarily the medical piece, but the psychotherapy piece, being able to talk to either a healthcare provider or just one another, is extraordinarily important.
Dr. Lawrence, do you see signs that people are tending to live longer than they used to? You've been in geriatric practice, as you said, I think 30 years. Do you think people are living longer? And if you do, what do you think is the reason for that?
Well, so we know definitely Americans are living longer. And I think just from the 2010 census to the 2018 census, there are, is evidence that, the mean age is up significantly over that almost 10-year period when this complete census was done. We know that life expectancy has slowly expanded. There was a huge jump in the early 20th century, and now the gains are more subtle. Mainly, it is now the science of advanced medicine that are making people live longer. So we definitely see that. We definitely see the silver tsunami. The baby, the older baby boomers now. So that, for example, in my practice of geriatrics in the office, I don't see people under the age of 80 anymore. I used to see anybody over age 65. In recent years, I realized people 65 to 80 are too healthy to see a geriatrician. So I see older people, and there's no question. I mean, that is those of us who practice a lot of long-term care and geriatrics, like Dr. Brus and myself, we're seeing people who are older, more complex, every day.
I know here at Barclay Friends, we were so sorry to lose our oldest resident who made it to 110. We were cheering her on to 111, but eventually her body gave out. But yeah, she was a prime example, and right up to 110, she was still moving around pretty well. So yeah. Dr. Lawrence, maybe you could comment a little. Dr. Brus just alluded to the fact that there's a benefit for people to be living in communities as they get older. And you certainly, I know you're not only the medical director here, you're the medical director at a couple of continuing care retirement communities. So you see the nursing home, the assisted living, and independent living. And do you see a benefit of individuals living in those settings, even in the nursing home setting, even in the assisted living setting?
Yeah, so part of that is, a safety issue, the safety of being able to receive supportive care that a person needs. For people with cognitive impairment, which is a significant percentage of people who need, long-term care, that safety part of it becomes a very important factor. We occasionally see people who are in the community living alone with advancing Alzheimer's disease, who have complications, including, paranoia, and they will not let their families help them. And as long as they're able to fight off any care that's offered to them, they can stay there, but it's extremely unsafe. So part of the consideration is safety. Some of it has to do with something as simple as food security, making sure a person can get the nutrition that they need. Some of it boils down to social engagement. So I have an aunt who lives with her older sister, and the younger is 91, and the older sister is 96. And the older sister has had some health problems, and the younger sister has never made a meal for herself in her life. So they're going to be moving to assisted living, and I know that they're both very, very social. That the social support and the opportunity for social engagement is going to be really good for them. I mean, we know that my younger aunt is really going to thrive once she moves. And there's always an adjustment period, but those are just, some of the considerations of going from, an independent living situation where a person doesn't need supports to a setting where they need support, and there can be, great benefits to that transition. There's always a transition period. It's never, really easy. And every transition is different and unique, but it's in the end, there really are a lot of benefits for people who need it.
Thank you. And we certainly see it here at Barkley Friends. We see individuals making new friendships. Occasionally we see a romance, so it is still possible in older age to enjoy life, to have fun, to make new relationships. So we do see that. I have one final question for each of you, and I'll start with Dr. Brus. Do you have an older person in your life, or had an older person in your life who inspires you? And tell us a little bit about that. Is it a patient? Is it an older person who might be a relative, a friend?
Yeah, I mean, actually, quite honestly, all of them inspire me. All of my patients, that I see in the facilities, and also those in my personal life. Every single one of them is an inspiration to me. If I had to choose one, though, there was one patient that I will just never ever forget. He was a young man at the time. He was a lineman, I think, for the Delmarva Electric Company. Long story short, he got electrocuted up on a tower, fell and died. They were able to resuscitate him, but he had burns over 90% of his body. And here he was, 25 years old with young children and a wife. And I took care of him, obviously, in his later years, after he had been through, the trauma and everything else. And just his attitude was infectious. He actually wrote a book. He gave me a copy of his book. It was called Dying to Survive. And he will forever be an inspiration for me. I brought the book home. I told my family about it. He's an inspiration to my kids and to my personal loved ones as well.
That's a beautiful story. Thank you. And Dr. Lawrence, how about you?
I sort of have inspiration on multiple levels. I told you first about my grandmothers who lived to be, I think, 88 and 99 in 2 months. And then my parents who lived to be 93 and 99 in 3 months. And then of course, thousands and thousands of patients over the years being in full-time geriatrics practice. Just in awe of the people I've seen over the years. There's also what we see in our common culture. So 2 things recently, of course, Betty White, and to see, everybody's appreciation of Betty White, who, in her middle career was pretty unimpressive, right? And in her late career, been this marvel. And then there's Captain Kirk, who, William Shatner, who at the age of 90 finally goes up in a spaceship. And I just thought that was really cool.
Final frontier, right? Well, that's great. And I just want to thank both Dr. Lawrence and Dr. Brus, both busy professionals for spending time with us tonight. And I know there are some questions in the chat. So Sean, do you want to lead us through those questions? And if people have other questions, feel free to put them in the chat at this point.
Yeah, we do. I want to be cognizant of everybody's time. I know at least one of you has a hard out at 5, but we have a couple minutes. I do have a couple questions in the chat. So let's start with how does one find a physician who specializes in geriatrics, and what should they be looking for when they're on that search? I don't know if maybe Dr. Lawrence, if you could.
Sure, I can start with that. So there are relatively few physicians with formal training in geriatric medicine, what we call fellowship training in geriatric medicine. The group I cover with at Mainline Health, actually, we have more geriatricians in our group than the faculty at the University of Pennsylvania in geriatrics. But we're all running around doing different things. So our time in the office, for example, is pretty limited. I'll say this, because of the shortage of people who have dedication to geriatric medicine practice, we really try to find those patients and hope those patients find us who really most need us. So a 70-year-old who may have a couple of chronic conditions, but otherwise doing pretty well, really doesn't need a geriatrician. They just need a good primary care physician, general internist, or a family physician who's interested and whose most practices, as Dr. Brus said in the beginning, most primary care practices now, senior patients are the most common patients they see. So it's more in that sense, finding the practice that is going to be able to support a person's needs as they age. But for those with special needs, such as people with dementia who need evaluation, typically you can go to any health system or hospital website that has an index of physicians, find a physician type thing, and you can find physicians who have special interest or expertise in geriatric medicine. If you find one with training, it's rare, so they're all pretty good. But I'll ask Rob to comment on how you find a primary care physician who has special interest or a practice that has special interest in senior care. That's tougher.
Yeah, I think it's hard. As Dr. Lawrence mentioned, certainly utilizing the resources of the local health systems can be helpful. But this is why my group does what it does. All we do is what's considered post-acute care. Our group of physicians specializes in just taking care of people in facilities, and obviously the vast majority of these people are in the geriatric range. And that's all we do. We don't have offices where we see younger populations. This is our full-time practice. And this is a subset of the population that needs that care and requires that subspecialty. And doing it day in and day out, and that's all you do, makes a difference in that level of care.
Thank you.
Can I add one other thing to that to support Dr. Brus's point? 20 years ago, the doctors who went to nursing homes were the office doctors who, on their spare time or at the end of the day, would stop by the nursing home or what was the personal care facility and see a few people. And the level of professionalism in the field of long-term care medicine has changed completely. There are more and more groups like Dr. Brus who are dedicated to long-term care practice, and the primary care doctors that just do it and fit it in, and it's a bother to them, is fortunately vanishing, because the level of professionalism there and dedication was just really lacking, and people needed availability with an urgent condition. There were problems with access and other things. So fortunately, that availability is changing now.
That's great. Thank you. And
Could I,
thanks, Bill,
could
for
I,
that
could I
question.
tag a question on to our two physicians? So
Sure.
there's a lot of older people living in the community that might have, a cardiologist, a rheumatologist. So the cardiologist managing their heart condition, the rheumatologist might be managing arthritis, and they might have some other specialties they're seeing. So what's the best way for a community residing older person to have someone sort of quarterback that? Because we sometimes see individuals that have had medication interactions because there isn't anybody quarterbacking that. So do you want to comment on that, Dr. Brus and Dr. Lawrence?
It's definitely important to have that quarterback. That's where that primary care physician, is important, because you do need that collaboration of care, and it takes that dedicated physician, someone that has that time, to be able to do so. But keep in mind, it is a care team, especially within a facility, in a long-term care facility. It's not just the physicians; it's also the nurses that are involved in that as well. And it's more of a team approach as opposed to an individual approach. But that collaboration is critical, especially in this population.
I'll just tag on to that point of, the quarterback's not always the doctor. And frequently, any given day in the long-term care setting, it's not the doctor. It shouldn't be it may be the nurse, the social worker, the therapist, the dietitian. So it changes, but it's that team care approach which is so important for in the care of seniors.
Thanks so much. Pivoting just a little bit, Anne asked about dementia. Is dementia inevitable? Can it be avoided by lifestyle choices or just managed? And Dr. Brus, maybe you could comment on that.
Is it inevitable? No, the answer is no. I wouldn't consider it inevitable. Certainly there is a genetic predisposition to it. So it's something that has to be considered and monitored, and possibly even treated. But I wouldn't consider it inevitable. I do think that as medical science advances, we will be finding, new treatments, new ways to help push it off. But again, it's not a life sentence just because someone in your family has it.
I'll add to that, I guess, by saying, dementia is a syndrome. There are many causes, the most common cause being Alzheimer's disease. And as many of you know, historically, the amount of research and research dollars dedicated to Alzheimer's disease, one of the most common health conditions we face, has been relatively little. So the findings and for such a common conditions, it's one of the things we really have not found effective treatment for. In terms of prevention, in general, the general statement, it's not preventable. But the other second most common type of dementia is vascular dementia. Dementia caused by vascular disease, most commonly people who have had strokes. And you get to the question, strokes prevent? Well, strokes are preventable by managing the risk factors for stroke: smoking, high blood pressure, diabetes, hypercholesterolemia, and so forth. So depending on how what type of dementia, there is some preventability certainly for vascular dementia.
Great. So those were my two questions. We did have a comment that we had touched on Social Security. And it says, when Roosevelt signed the Social Security Act back in 1935, those who entered received benefits for 2.5 years. Of course, many people did not live to 65. And then when it was becoming short of funds in the 90s, the survivors were about 60%. So you can see the dramatic increase there. I know it's not exactly your specialty, but do you have any thoughts on the financial implications? I know, 40 years from now, I often think what Social Security is going to look like for myself. But yeah, maybe if you have a comment on that.
I'll make a general comment about the impact of financial resources on aging. What we know is there's major concern, not just for individuals, but for the government, that with people living longer, they are going to outlive their financial resources. And, Social Security, the health of Medicare are key factors there. It's a real concern. I don't think anybody has the answer.
Absolutely. It's definitely a concern. Just from the overall 30,000-foot perspective, with all these stimuluses, these trillions of dollars that have been pumped into our economy, the Medicare funding, Social Security funding, it's always just been kicked down the road. I feel sorry for my children and their children, who it's probably going to eventually catch up with.
Very nice. Thanks so much.
And I had a comment about finding a geriatrician. This is coming from my experience of living in Delaware for many years. I taught at Christiana Care Hospital down there for about 10 years. And what I discovered is that there were, both among the internists and the family physicians, particular physicians who were interested in doing geriatric care. And it seems to me, one of the ways that I have found physicians that I want is to talk to training programs that are nearby. I'm not sure if Penn has a corner on the market here, but talk to them and say, okay, your docs who are coming out of your residency, who's interested in working with geriatric patients? And I think that's the way I have found a number of good physicians over the years.
Interesting. Thank you.
I just want to comment that it's an excellent strategy, because you also want your doctors to be younger than you and not retire on you when you need them. So that's a good strategy.
Definitely. Well, it's exactly 5 o'clock. I think that's a great point to wrap up here. I want to thank you, Dr. Lawrence and Dr. Brus, for joining us today. I thought it was a great event. Just a reminder to everybody, we did record this session, and if you had RSVP'd online for this, we're going to shoot it out probably in the next couple days. But thanks again, everybody, for joining us, and everybody have a great night.
Thank you to the two doctors. Appreciate
Thanks,
it.
everyone.
Thank you.